Hey guys, good afternoon. Let's enjoy the chest radiographs with Dr. Y. Today's will be session 15, adenocarcinoma, lung cancer. Let's enjoy the chest radiograph with chest radiograph Dr. Y. Before entering to session 15 of adenocarcinoma of lung cancer, let's review the session 14. This is very, very important. I hope all of us remember in the heart about this review. Number one, lung cancer used to be and still now and probably will be a terrible disease. Number two, just don't smoke. What Yul Brynner said before he was dying of lung cancer gives us the peace in the mind and the body. Before facing the chest radiographic findings of lung cancer, the adenocarcinoma, I would let you know some facts, some statistics about adenocarcinoma. Let's begin. Adenocarcinoma is one of the non-small cell lung cancer, accounts for 40%, number one cancer, of all lung cancers in most countries. There is a strong association with smoking and adenocarcinoma of lung cancer. Adenocarcinoma starts in glandular cells which secrete substances such as mucus and tends to develop in smaller airways such as alveoli. Adenocarcinoma tends to grow more slowly than other subtypes of lung cancer. Adenocarcinoma is the most common subtype to be diagnosed among never smokers. Adenocarcinoma usually occurs in the lung periphery and may be found in scars or in areas of chronic inflammation. In addition to existing treatment, promising new treatment approaches are being developed in adenocarcinoma therapy. Adenocarcinoma is more often found in women. In younger patients, the adenocarcinoma is more likely to occur than any other subtypes. This table is the classification of adenocarcinoma resection specimens year 2011 made by International Association for Studying Lung Cancer, American Thoracic Society, European Respiratory Society. At first glance, we may be frustrated with the complexity of the contents, but after finish the session, we will feel more comfortable with this classification, I'm sure. They categorized into 4 types. First is pre-invasive lesions. Second, minimal invasive adenocarcinoma. Third, invasive adenocarcinoma. And fourth, the variants of invasive adenocarcinoma. Going up means less invasiveness. Going down means more aggressiveness. Let's divide the contents into 2 pages. First page is number 1 and number 2. These 2 types usually manifest themselves on the radiographs, on the CAT scan, as ground glass opacity, subsolid nodules. Let's go to first one. The pre-invasive lesions. In this category, there are 2 types. A. Atypical adenomatous hyperplasia, in brief, AAH. B. Adenocarcinoma in situ, AIS. In AIS, we divide it into 3 subcategories: non-mucinous, mucinous, mixed mucinous, and non-mucinous. Mucinous is usually more aggressive than non-mucinous type. 2. Minimal invasive adenocarcinoma. In brief, we call it MIA. Also, we have 3 subtypes: non-mucinous, less invasive; mucinous, more invasive; mixed mucinous and non-mucinous type. These pathologies usually manifest on radiographs and CT as ground glass nodules. Third category is what we usually meet in the hospital reading room. Third, invasive adenocarcinoma. Most of the adenocarcinoma manifest as invasive adenocarcinoma, from less invasive to more aggressive as A to E. A. Repeated predominant form. B. Acinar predominant form. C. Papillary predominant form. D. Micropapillary predominant. E. Solid predominant with mucin production. And fourth category, the variants of invasive adenocarcinoma is most invasive among them. Let's look into the famous term ground glass nodule, GGN. Ground glass nodule. We call subsolid nodule when we find pure ground glass nodule and plus part solid nodule. These 2 categories are included into one term, subsolid nodule. Ground glass opacity versus solid component tend to correspond respectively to repeated versus invasive components observed pathologically. This means GGO usually represents repeated growths, and solid component, part solid component, usually shows invasive components in the pathologic slide. I have told you before that there is no specific findings of lung cancer subtypes, but there are some genetic findings of radiographic findings of adenocarcinoma of lung cancer. Because most of them are peripheral type, they usually represent as a subsolid nodule, or solitary permanent nodule, or mass, and even consolidation. These 4 categories are their usual manifestations. Adenocarcinoma of lung cancer. Life cycle of adenocarcinoma of lung. Actually, there is no granted form of term like life cycle. This is just what I feel, Dr. Y feel when in practice, that ground glass is going to grow to somehow to mass. So let's think it as a joke. Just at the beginning, it is just a pure ground glass nodule, and sometime later, very slowly grow into part solid ground glass nodule, and sometime later they become solid nodule, so-called solitary permanent nodule, and then very rapidly into mass. Now let's begin the show. What do we see? This is thin section lung window setting. CAT scan, X-ray image. What do we see? Yes, this is a relatively pure ground glass opacity. Yes, the chest radiograph showed nothing. Normal chest radiographic findings. This is pure ground glass nodule with this thin black area is sometimes we call it bubbly lucency. Bubbly lucency, somewhat characteristic of adenocarcinoma spectrum. Pure ground glass opacity of about 2 cm. What do we see in this film? You got it? Okay. Right upper lobe. Sure, that's right upper lobe. This is minor fissure, so that's right upper lobe. This one, about 1.5 cm, somewhat increased opacity. Yes. Let's look deep into the lesion pathology. This is a thin section long window setting. How do you feel? Is this lesion matched with this one? Yes, right upper lobe, 2 cm. The periphery is pure ground glass opacity. The central portion is dense white area, so we call this as solid portion. So this nodule is part solid nodule. Maybe we don't know sure. This will be in category 2, minimal invasive adenocarcinoma, but we do not know actually if we do not mapping this one on the whole image. Part solid ground glass opacity. How about this image? Yes, sure, it's good. We find something here. Yes, maybe here. Okay, this woman looks relatively young woman with a right upper lobe ground glass opacity. This is thin section CT XR CAT scan. What do we see? Bigger and denser subsolid nodule than previous case, with the speculation approaching to the pleura, more aggressive looking, and the pure ground glass opacity area is even looking not so pure, and central portion is more denser, and we see intratumoral air bronchogram here. Yes, this should be more progressed form of part solid ground glass nodule, adenocarcinoma. What do we see with this young lady's frontal chest radiograph? She's never smoker and very young. Yes, this nodule here, below minor fissure, so it is not in upper lobe, maybe in middle or lower lobe. This is the thin section CT, solitary pulmonary nodule of right lower lobe. Doesn't this nodule look like just evolved from subsolid nodule to solid nodule? For me, it looks like that, with internal tumoral air bronchograms. Do you concur? Interesting. This is a frontal radiograph of a woman age of 60s without symptom. 1 centimeter nodule here, middle lobe or lower lobe, I don't know. We do not know from this image. Yes, it's in the middle lobe. 1.3 centimeter nodule with many speculations. Yes. How about this? Bronchus is attaching to the nodule. Previously, we called this as a sign, CT bronchus sign, meaning lung cancer, but that does not always true. So just forget the sign, name of the sign, CT bronchus sign. Just forget it. This is solitary pulmonary nodule. The nodules of this section is going bigger and denser, going more aggressive, going with more tumor volume. This nodule is in right upper lobe, definitely dense, bigger, and more aggressive looking with this many spiculations, corona radiata spiculations, invasiveness, looking just like sea urchin. Have you ever seen the sea urchin? With many spines and needles. That means very aggressive tumor. How about this one? Very large mass, 7 centimeter, and overlapped with the left heart. That means retrocardiac. There is no precardiac space, so it's only in left lower lobe. Left lower lobe, large lung cancer mass of adenocarcinoma. In this CXR image, this is large solid mass in left lower lobe location. How about this mass? This is an old man, heavy smoker. We have seen this image before. Yes, peripheral mass with 9 centimeter. More than 7 centimeter means T4 staging. T4 staging is not good for the patient. Yes, T4 staging, right upper lobe mass, adenocarcinoma. Another case of 9 centimeter mass in left lower lobe, not overlapping with the heart border. So the mass is mainly in the left lower lobe. Yes, very large peripheral mass, T4 staging in the heavy smoker of old man. This is the last case of this session, and I hope you pay more attention to this patient. Just looking like right upper lobe pneumonia, monofiscial, Mach band defect, air bronchograms, and consolidation. But she doesn't have many respiratory symptoms, not like pneumonia. No much cough, no much sputum. So it's very complicated. At first glance, we used to say that this is, this is right upper lobe pneumonia, alveolar pneumonia, and bulging fissure sign. But this isn't true. She had this image taken 1 month before. I see no significant difference between 1 month's difference. That means this isn't not a simple pneumonia. Pneumonia doesn't stay so long without change. Go down or get better. That's the pneumonia course. So this is strange, not pneumonia. This is her actual contrast-enhanced CT image. How does it look like? Homogeneous airspace consolidation with air bronchograms. Just look like alveolar lobar consolidation of pneumonia. But she was proven as mischievous adenocarcinoma. Now we have finished session 15 of adenocarcinoma of lung cancer. Very various spectrum of findings, from ground glass nodule to huge mass and to airspace consolidation. The spectrum is very wide, and most importantly, adenocarcinoma is increasing and the #1 lung cancer subtype. We must remember the importance of adenocarcinoma and the spectrum of the radiographic findings. Okay, congratulations for the finishing of session 15. Now let's go to the answer of the quiz. There is a chicken egg, hen's egg shaped calcifications, secretly of chronic liver abscess. Have you ever read the book named Damien of Hermann Hesse? A bird fights its way out of the egg. Something like that? Just like a hen's egg. Yes. Are you correct? Congratulations. This is the quiz for the next session. What happened to these patients and what for that happened? Before closing the adenocarcinoma session, I would say 2 paragraphs to all of you and me, all of us. First, smoking causes cancer through all metabolic pathways from the mouth to the urinary bladder. 2. So, smoking causes 60% of all cancer deaths all over the world. The next session will be about the findings of large cell lung cancer. Large cell lung cancer is very notorious about the worst prognosis among lung cancers. Like, subscribe will be a big support to Chest Radiograph Dr. Y. Thank you very much.